Thank you for joining the Heilbrunn Department of Population and Family Health Spring 2021 Seminar Series. Today's seminar is the first of a two-part series featuring work of the Global Health, Justice, and Governance Program. Our speakers today will discuss gender-based violence, sexual and reproductive health and rights, and COVID-19 in the United States.
The intersection of COVID with pre-pandemic sexual reproductive health policies and GBV policies. So how did that all come to a head with the onset of the pandemic? Next slide, please. So there's three really major components to this mixed method study. There's a desk review and policy analysis that really aim to document government responses and policies implemented during the pandemic that have affected GBV and SRH services and programs. Also shifts in availability of GBV and SRH programs and how COVID-19 has really affected the SRH and GBV needs of historically overlooked populations. Key sources included academic literature, reports and publications from rights-based organizations, news articles, and things of that nature. There was also a qualitative interview component, which Malia and Jen really led the way on, conducting 24 interviews, and we'll present those results for you today as well. And then there was a survey that was done in all 6 countries, including the US. And we had 97 individuals who completed the survey. The survey really targeted service providers. So I'll talk a little bit more about those findings as well. Next slide. So
briefly,
Jen, go ahead.
Yeah, thanks, Dr. Samari. I'm going to walk through a timeline that highlights some events in the US leading up to and during about the first 6 months of the COVID-19 response. And while far from comprehensive, we just wanted to note again some of the ways in which the pandemic converged with and exacerbated gaps and disparities related to GBV and SRHR in the United States. So prior to the pandemic, restrictions on abortion funding through the Trump administration's domestic gag rule cut the nation's public family planning program capacity in half. During the spring and summer of 2020, the US response was characterized by fragmented political leadership, massive economic downturn, the politicization of public health guidance, and piecemeal implementation of public health recommendations. Some government officials seized the opportunity to push anti-immigration and anti-abortion agendas. For example, in March, officials used the pandemic as a pretext to begin blocking asylum seekers, often leaving people at the US-Mexico border vulnerable to high rates of violence. In April, a federal appeals court allowed Texas to continue blocking abortion access under pandemic emergency measures. As the US neared 100,000 COVID deaths in June, the nation was concurrently experiencing mass protests and civil unrest in the wake of George Floyd's murder. And in September, the US reached 200,000 COVID deaths, more than any other country in the world. And of course, as you know, the number of deaths has again doubled since then to over 400,000. Next slide, please. And so with this context in mind, we're going to move into a more specific discussion of the state policy responses to COVID-19. Next slide. In the absence of an adequate federal response, state-level responses largely determined the on-the-ground realities for service providers. Orders to stay at home and decisions about essential services emerged as particularly important in determining how services were provided and who was able to access them. And our next few slides run through a series of maps showing where these policies were implemented and illustrating just how fragmented the SRHR and GBV response has been. So this map shows how backing up a minute, I'll just mention that all states except for South Dakota closed non-essential businesses in March and April. And 21 states, shown here in green and in stripes, designated some or all SRHR services essential. Precise protections varied by state and ranged from essential designations for reproductive health services to pregnancy-related procedures to all healthcare services. Protections weren't always comprehensive. Only 12 states, the states shown in stripes here, protected abortion as an essential reproductive health service. Next slide. And this slide adds GBV protections shown in purple. We see that SRHR and GBV protections weren't necessarily implemented together during the COVID response. Only a few states, shown here in stripes, protected both. Most of the states that enacted GBV protections focused on exempting domestic violence survivors from mobility restrictions, which were enacted by most states in March and April. Some states like Minnesota included these exemptions for DV survivors from the onset, and others added exemptions in amended or additional emergency measures in the months into the summer and fall of 2020. Next slide, please. And this slide adds abortion restrictions to the mix. Altogether, 11 states, shown here in red, acted to suspend abortion as part of their COVID-19 response. We even see that 3 states, the states in red and green stripes, designated some SRHR services essential, while also acting to suspend access to abortion. Through the spring and summer, these restrictions on abortion heightened confusion and uncertainty among providers and patients about where, when, and how to access services. Next slide. And so when we sort of put all of these maps together and look at protections related to SRH, GBV, and abortion, we see that really only 8 states, shown here in green, acted to protect each of these areas, underscoring just how uncommon something resembling a comprehensive policy response was in the United States up to September 2020 or so. Our qualitative interviews show that these policies had critical implications for service providers. Where protective policies were not in place, providers experienced more confusion, closures, and delays. Where protections were in place, providers were able to continue operating with fewer barriers. Next slide.
Great. Now I'll discuss some of our survey findings, which, as you'll see as we discuss the policy findings, the survey findings, and the interview findings, there's quite a bit of overlap in the themes that have emerged, which is always nice to see in mixed methods findings. So we find similar threads throughout the study about who was impacted, how were they impacted, and what populations were overlooked. So next slide, please. So a little bit about the survey. So because every state has a little bit of a different environment, and as you saw, some states protected SRH, the definitions of that varied. Some states protected GBV, some states protected both, some states restricted SRH. So we wanted to create, a targeted outreach for the survey participants that really sort of would be a sample to represent the US as a whole. So we selected 10 states, Louisiana, Maine, Minnesota, New Mexico, New York, North Carolina, South Dakota, Texas, Washington, and Wisconsin as sort of representation of the US as a whole. So they offered regional representation. They offered diversity in terms of the extent to which COVID restrictions protected or limited SRH and GBV services. And they had a different demographic makeup. So we sought states with sort of high populations of historically overlooked groups like Black, Indigenous, people of color, incarcerated, asylum seekers. We also selected states that were COVID hotspots early in the pandemic. And we basically took that list of states and we identified SRH and GBV service providers in each of those states. We compiled a list of about 500 service providers and then sent the survey that was designed to be similar in all 6 countries that the study was taking place. We received about 145 responses from 500 organizations, and we had 97 respondents who completed the survey as a whole. As you can see on this map, various states had more representation than other states. So Texas was quite a bit represented in the survey response, says as was New York and Minnesota and Wisconsin. We had about 50% of respondents who worked in GBV. We had 23% that worked in both GBV and SRH. And we had 22% that worked solely in SRH. But nearly all of these organizations said that their work had been impacted by COVID-19. So 99% agreed that their work was impacted. Next slide. So this also shows you the types of organizations by region. We see that nonprofits and shelters in the South are the most represented. We see that community-based organizations from the Northeast are also well represented in the results. We don't have any health facilities from the Midwest, which was kind of interesting. But overall, there's a good mix of NGOs, CBOs, health facilities, and shelters, and then organizations that identified as others or kind of did a combination of this work. Next slide. We asked the survey respondents about their primary role within their organization. We had about 32% were program managers, we had 99% community health workers, and then 40% identifying in other roles. We also asked these organizations what age groups they served, and you had about over 40% that served children and adolescents. 24% were really focused on adults, and 36% said they focused on all ages across the life course. Next slide. So COVID-related disruptions were really brought to light. As I said, 99% of organizations were impacted by COVID-19. In terms of GBV, 74% of survey participants identified disruptions in clinical management of rape or other gender-based violence. 46% reported disruptions in community-based GBV prevention and awareness activities, and 23% in counseling or psychological services. So this is really striking when you think about treatment and care for gender-based violence and prevention of further gender-based violence. Next slide, please. In terms of SRH, there were issues sort of throughout different aspects of SRH. 27% said that there was disruptions in community outreach and awareness. You had 13% disruption in abortion care and post-abortion care, but you had similarly like 12% disruption in contraceptive counseling and services. Also, adolescent-friendly or focused services, there were disruptions at around 12%. So again, across the SRH spectrum, you really see disruptions in all sorts of services. Next slide. So as I mentioned, with any work, there's always going to be populations that are underserved, and which creates disparities in access. And so these organizations really identified, 46% said that migrants, refugees, and displaced populations were not receiving services. So that population came to the surface as one that was really being underserved. Also, Black, Indigenous, and people of color, 45% of the organization said that these groups were not receiving GBV and SRH services. You also had 37% of women with disabilities and around 31% of adolescents. So this really shows, where the gaps in care were, particularly at the onset of the pandemic. And with that, I will pass on to interview findings.
Thank you. Yeah, so now that Dr. Samari has provided a snapshot of our survey findings, I'll be going through some of the cross-cutting themes that emerged from the interviews. The interviews really offered an opportunity to get at the intersectional nature and nuances of COVID's impact, perhaps not captured in the survey data. So we conducted 24 interviews that spanned a range of states, organization type, and population served. As you can see here, we ended up interviewing a few more SRHR organizations than GBV. This was in part due to the fact that SRH encompasses a wide range of services, and we wanted representation from, for example, family planning clinics, abortion providers, LGBTQ clinics, teen programs, and maternal child health programs. The large majority of interviewees, almost 80%, were direct service providers, but we also spoke to one funder and 4 organizations doing advocacy and policy work. Most of the people we interviewed held leadership positions within their organization. So for example, they were the director, founder, or held another high-level role. We sought geographic diversity as well, in interviewing at least one organization in each of our 10 key states that Dr. Samari mentioned earlier. I'd also like to note that a few of the organizations we spoke to worked in multiple regions. So COVID-19 impacted numerous aspects of our interviewees' work. As you might expect, respondents experienced significant disruptions to their operations. For SRH providers, the shift to telehealth was disruptive, especially in cases where infrastructure and support were lacking. For GBV organizations, virtual platforms allowed services to continue, but the adjustment was pretty slow and cumbersome. On-site staff in both SRH clinics and GBV shelters had to implement social distancing, sanitize more frequently, and manage constantly changing protocols, which increased workload as well as frustration in many cases. Hospital and prison policies that restricted access for GBV advocates or doulas further complicated operations, as evidenced by this quote from an SRH provider, which I will give you a moment to read. And a GBV provider described the impact of operational changes as follows, quote, "The human presence is so important in our type of work, and that's definitely lost. That has affected morale and that has affected participants. It's hard to have an emotional, open conversation via screen." While most organizations have continued providing services, they describe temporary reductions in the availability of certain services, as well as reductions in the quality of those services. Family planning clinics we spoke to had not rebounded to pre-COVID service volumes yet. One abortion provider noted that they dropped gynecology as a regular program because of COVID, saying that they put it on the back burner except for maintenance. HIV STI clinics reduced their hours and the number of patients that they were seeing each day. School closures severely decreased health education services available to teenagers. GBV shelters limited their capacity, closed or restricted who was allowed to stay, although in some cases, hotels did supplement this capacity. In some states, as Jen discussed, providers had to navigate abortion bans, which impacted service provision. This also had an impact on neighboring states, some of whom we spoke to, who subsequently saw an uptick in patients crossing state lines for abortion care. Policy organizations we spoke to had to adjust to shorten legislative sessions and have seen their advocacy efforts deprioritized by local government officials. One interviewee described it as feeling, quote, "perpetually on hold." And then an SRH organization who pre-COVID had regularly gone to tabling events and community meetings to conduct outreach noted the following, which I will give you a moment to read. On the service utilization side, GBV organizations saw a dip in clients following stay-at-home orders. As one GBV provider explained, quote, "Although we never closed our doors to walk-ins, we saw a dramatic decrease because either people just assumed everything was closed or they didn't want to go out in public to avoid exposure." GBV advocates continued to do court hearings with clients via Zoom, but virtual hearings were described as cumbersome by one interviewee and therefore served as a potential barrier for clients to get support and advocacy. For SRH, demand for home births was described as skyrocketing with not enough midwives to meet the need. And interviewees also described decreased access to abortion, as we mentioned, for the populations that they serve. This was especially true for teenagers whose mobility was severely restricted under stay-at-home orders, as described in this quote from an SRH provider in Texas. And then in terms of funding streams, some organizations had to cancel or move fundraising events online, putting them in danger of coming up short on fundraising goals. Other organizations were concerned that reduced patient volumes translate to less revenue. Some funders did increase flexibility during COVID, which was described as really helpful from the recipient's perspective. So this meant shifting grants to general operating to help grantees cover overhead, keep the lights on, or adapt to the immediate needs of their clients. Despite a short-term surge in emergency funding, many organizations did express uncertainty about the future. As described by a GBV provider, quote, "We have had an onslaught of emergency fund opportunities, but in terms of refilling the coffers and being available for grant making at the end of 2021 or so, that's what gives me anxiety." Jen?
And I'm going to pick up with a discussion of underfunded and underserved groups in our interview findings. Similar to the survey findings that Dr. Samari discussed, interviewees identified a range of underfunded and underserved groups. Youth were among the most frequently mentioned as having unmet needs during the pandemic. As Malia pointed out in the discussion of service utilization, school closures meant access to confidential SRHR services and health education became much more limited. Many interviewees also pointed out their limited capacity to provide services in languages other than English, and service providers recognized fear of immigration enforcement as limiting access to services. Next slide, please. As an SRHR service provider in New Mexico described, people were concerned about crossing through ICE checkpoints while traveling to their facility, saying that people are like, "I don't think I can do that. I don't feel safe." Next slide, please. Other interviewees focused on constraints related to funding, with funds sometimes excluding particular groups from accessing services. According to a GBV provider in Wisconsin, one of the problematic things about our funding is that we cannot work with people considered, quote, offenders. Next slide, please. While COVID has clearly brought on a fair share of adverse impacts to SRHR and GBV work in the US, respondents did highlight a few silver linings. For instance, they noted that in some cases, remote services allowed them to reach more people and new audiences. The pandemic also pressured some organizations to innovate, serving as a catalyst to implement long-sought changes. Next slide, please. A GBV funder in Minnesota reflected on the spring and summer of 2020 as a time for transformation, experimentation, and innovation, saying people are willing to do things they haven't before, so let's take advantage of that. And I'm going to take a moment to recap some key facilitators and barriers that came up during our interviews. Thinking back to the mapping of emergency measures at the beginning of the presentation, we also saw in the interviews that state policy played a large role in shaping service providers' responses. Many interviewees referenced state executives, congressional representatives, and health department officials. In states where services were designated essential and where pre-pandemic policies, such as abortion restrictions, were low or didn't create many barriers to accessing services, providers generally reference state officials as facilitating continued service provision during the pandemic. But in states where the pre-pandemic policy landscape already limited access to funding for SRHR and GBV services, COVID-19 added a new layer of difficulty. In some cases, this related to concrete restrictions, like the abortion bans we mentioned. But in many cases, it related more to heightened confusion and uncertainty among both patients and providers about how to access services, when and where services would be available, especially as partner organizations closed, people struggled to access accurate information, supplies and staffing were interrupted, and COVID-19 testing remain difficult to access in many regions. For organizations working across the US-Mexico border, travel restrictions complicated the situation even further. On the flip side, under facilitators, organizations that already had telehealth platforms in place that allowed for remote work prior to the pandemic, that were engaged in local emergency preparedness activities, or that anticipated some of the supply challenges, for example, in PPE, were better able to adjust to the pandemic and continue providing services. Next slide.
Great. So what are we going to do with all this information? So I'm going to talk a little bit about future directions and where we hope to see this go. So we're producing a series of papers and briefs that really highlight both the SRH implications and the GBV implications, but also sort of discussion of these things together, because we noticed that there was this piecemeal response and gap in the response, and sometimes GBV was elevated and sometimes SRH was elevated. So we really want to draw attention to not only like the funding origins of that disparity and discrepancy, but also like what can it look like if we actually have an integrated response. Also, I believe next week there will be a presentation on the other 5 countries that were included in this study. So I would recommend tuning in for that, because that'll highlight the findings from all the different countries. And it's interesting to see that while some themes emerged in the US and across all countries, there are also like certain populations that are increasingly underserved due to unique vulnerabilities in certain country settings. And we hope to also take some of this work to those that participated in the research to, show them and those organizations what the findings were in order to help their operations and grant making moving forward. So those are the future directions, and then ongoing considerations about, now we're 11 months into the pandemic. So what are the implications for SRH and GBV now? Have people adjusted? So continue to look and answer those types of questions, as well as the Global Health Justice and Governance Program moves forward with this portfolio of work. Next slide, please. I think it's important to acknowledge our funder for this work. I also think that it's important to acknowledge the entire research team led by Professor Terry McGovern and Neetu John. Many of the research team members are here today, and it really would have been impossible to do this work in all 6 country settings in such a rapid and timely manner without the support from those of us who presented today and those of us who are part of this research team. So thank you to everybody who was involved.
Okay, thank you so much. So I just wanted to underscore that the Ford Foundation supported this work, and they're most interested in, kind of how can we work with community partners to actually have an impact or inform their advocacy strategies as we move forward. So I wanted to ask you all, whoever wants to answer, what could have prevented this mess? That's a really big question, but even small things, like I feel like we read document after document about how things are supposed to go, and somehow it all blows up. So any thoughts on that?
I can start us off. So I think the US is kind of interesting because the states control a lot of the policy environment, particularly around SRH and GBV. And so I think that's unique to the US. There was no coordinated federal response, right? So I think we could have prevented some of it by having some sort of coordinated federal response that included GBV and SRH as essential. But also, like, those types of policy declarations are meaningless unless they're coupled with some sort of implementation plan, or like, what does this mean for these service providers and actually reaching the populations that need to be served? So I think it's like twofold. It's like, one, coordinated a federal response with a clear policy directive, but also coupling that with either resources or guidance about direct implementation of these services.
So before I turn to either Jen or Malia, I just wanted to say, of course, we also have the historic siloing of GBV and SRHR, which, of course, these problems present in the body of an individual. They don't present in silos. So I think that's haunting all of this. Malia, were you going to say something?
Oh, just to add to what Dr. Samari was saying, I think coming from the state officials and federal officials, that would have been really helpful. But also on the ground, we heard from a lot of our interviewees that communication was just a really big issue. And this kind of theme of our clients or our patients didn't know that we were open, or they didn't know what services were available during this time because everything was changing so frequently. So I think just a more streamlined communication. I mean, folks were saying that they were just posting on their Facebook, saying that whether or not they were open, but that obviously requires clients to go to the Facebook page, which not everybody may have access to. So I think that was a big thing that could have helped as well.
Great, thanks, Malia. Jen, anything to add?
Yeah, I think just to build a bit on what's already been said, kind of thinking back to those maps, we see that historic separation of SRHR and GBV policies and responses. So in addition to that coordinated federal response that Dr. Samari was referencing, also a comprehensive federal response, right, that addresses GBV and SRHR together.
So that's really helpful. A couple of questions. One is, obviously in several of these states, there's been a kind of concentrated effort to deny access to abortion and access to sexual and reproductive health. How much opportunism do you think was going on here, and any comments on that? And then secondly, we're hearing a lot about the Biden-Harris response to COVID. And I'm wondering if anybody has any thoughts on whether you're seeing reference to any of these issues in those plans. Just so those are two hard questions, but I think pertinent.
I can speak a little bit to the first one. I was able to conduct several of the interviews that we did in Texas and Louisiana with providers there. And I think in terms of opportunism, yes, that was certainly an aspect of how restrictions were rolled out and protections were not put in place related to SRHR and GBV. Several of the providers I spoke to in those two states kind of said, well, certainly we were disappointed to see these restrictions come into place, but we weren't surprised. This happens time and time again in the states where we live, and that's the policy context within which we were working for years leading up to the pandemic. It will continue through the pandemic and probably continue after the pandemic as well.
That's very, very helpful. Anyone else on how we're feeling about, or how we can impact the Biden-Harris administration if we're not seeing clear reference to these issues? Go, Dr. Samari.
I mean, you might know more about this than I would know, but I have not seen very much reference to a integrated SRH and GBV response policy proposal to COVID-19. And so I think some of this work about the impacts early on should be really used in an advocacy way to really demonstrate that these services are essential, that populations are not getting what they need, and that it really does need to be part of the response strategy.
Yep. Anybody else? I want to again encourage our audience to please send in some questions. Malia.
I was just going to add that, while we haven't seen a lot of SRH GBV integrated policy yet, it's still early, but there is a lot of talk of immigration reform, and I think that will have a big impact. That was another topic that came up in our interviews, how immigration policy impacts what these providers are seeing on the ground, and kind of how they have to circumvent certain restrictions in order to serve populations that are, quote unquote, undocumented. So I think that will be interesting to see play out.
Mm-hmm. And I'm wondering also if there was an impact from the domestic Title 10 gag, if you think that was at issue here, just in case everybody doesn't know. Of course, everybody probably knows what the global gag rule is, but the Trump administration did the same in the US. I understand it's interesting because in other Democratic administrations on the first day, the gag rule, the global one, was lifted. And I understand it's slated to be lifted on the 28th. So I'm very engaged with many people who are watching very closely. But I was wondering if you saw the impacts of, say, the Title 10 gag, the public charge rule, all of these kind of horrible governance issues that we saw that were in the mix, or weren't they? I mean, can you talk about that a bit?
So, short answer, yes, but I think it's hard to piece apart. So these organizations were really being pounded, like public charge, then Title 10, like domestic gag, and so it's hard to piece apart. COVID hit when these things had just been basically implemented maybe like a month or two before. And so organizations, I think with the groups that they talk about not being able to serve adequately, it's a reflection of those policies. When migrants and refugees and displaced populations come up to the top because people are afraid to get care because of public charge rules, but it's also like amplified in COVID. It's why a lot of people get frustrated when people talk about COVID related disparities, but don't talk about like the underlying drivers of those things, which is a lot of these major policy positions. So Jen and Malia can talk a little bit about whether the interview participants actually referenced those things, but I know that it drove some of the disparities that we saw in the results.
Mm-hmm.
Jen, I feel like you maybe had a few more interviews with organizations serving immigrant communities.
Yeah. And I know Title 10 specifically came up in a couple of the interviews that I did. And kind of as Dr. Samari mentioned, it really came out in reference to those underfunded, underserved groups, right? So thinking of an organization we talked to that worked with youth in Texas, Title 10 clinics are where youth living in Texas can access confidential SRHR services. And with fewer and fewer Title 10 clinics in Texas and teens having to travel farther to get to them, teens being stuck at home, the changes to Title 10 were really overlaid then by the pandemic, making it even more difficult for youth to access those services in one of the very highly restrictive contexts in the United States already. Another example that comes to mind is Maine. So Maine actually it shifted it no longer received Title 10 funding for family planning clinics, and was in the process of trying to shift some of that to state funding, right, to replace that lost federal funding with state dollars. And when the COVID-19 pandemic hit, the legislative session in Maine actually shut down. And with that, they were not able to see whether this bill to get state funding could be pushed through the legislature. So it really exacerbated the uncertainty around the lost Title 10 funds and the ability to replace them with other funds. So at the time we spoke to the interviewee, many clinics in Maine were still relying on kind of supplementary funds from private foundations. But we're looking to figure out how they could sustainably continue to fund family planning services in the state.
Great. I was just also wondering if we could talk a bit about maybe are some things we could do, our students could do, our faculty could do to impact what, kind of the policy around these issues in this new administration. That's one question. And then secondly, I'm just wondering, particularly Malia and Jen, how it was for you to work on this project, since you're One of you is a recent graduate and the other is still in school. What surprised you? Just any reflections, because this was a huge project, which I think you managed brilliantly. So first question, what can we do? Any thoughts on that? Second, just reflections on how it was to be a part of this research. So what can we do?
I'll start with the second question because it's a little easier.
Okay.
No, so I think as a recent alum, it was really just interesting to, you learn about these things in the classroom. We talk about them so often, but to actually talk to the people who are experiencing it, and not necessarily just in New York City, but throughout the country. I mean, I spoke to people in states that I haven't had the chance to go to before. So it was really helpful to just kind of understand the different contexts under which each organization was operating and the different types of challenges. But I think what really shone through to me was just the immense impact of state policy on, operations on the ground. And I think another thing was that, in public health, we often talk about the patients and the participants in programs, but something that came up a lot in the interviews, at least, was, we were, as I mentioned, we were talking mostly to founders or directors, and they had such a huge concern for their staff and who were having to, bear the brunt of a lot of this. And so I think that was just kind of another perspective that we don't always talk about as public health practitioners.
Great, thanks, Malia. Jen, anything to add?
Yeah, I would just add that, as a student kind of sitting between public health and public policy, you probably got a sense of this as I was speaking in the presentation, but I was just really fascinated by the opportunity to analyze the policies, look through the state emergency orders, compile that, and then talk to service providers about kind of what they were experiencing on the ground. So how does this body of policy language put into state orders translate then to the experiences that people are having and the ways in which they're able to serve patients and participants in their programs? And I think also coming from the Midwest, I grew up in Minnesota and Wisconsin, I really, really enjoy the opportunity to speak with service providers in those states and get a sense of what was happening there, just being quite familiar with that context.
Great. Thank you both. We do have some questions now, and maybe we can come back to this issue of what can we do. The first one is from Kelly Hall, and then I'll go to Dr. Garbers. Dr. Hall, we've seen how COVID has only dramatically elevated the complicated intersections of not only GBV and SRH, but also urgent health threats and public health priorities for women worldwide, specifically related to mental health, substance abuse, suicide, overdose. I'm wondering if any of your interviews uncovered thoughts and directions related to coordinated care and policies that might facilitate those. I don't know, Sam, is your question related to that?
I was halfway through typing it. I just want to say it was such a really great presentation. Jennifer just mentioned that you're taking quantitative data and qualitative data and policy scans and really providing like a 360-degree view of what the next steps are. And I was wondering what the next steps were in terms of getting these findings out, sort of out of here and out into practice. What your thoughts are?
Great, Sam.
Or plans.
So let's just go first with, have any of your interviews uncovered thoughts and directions related to coordinated policies that might facilitate those?
So I'll let Jen and Malia talk about that, but actually, interestingly enough, I have a study in the field right now that's specifically speaking to immigrant women about their SRH needs during COVID, and this has come up quite a bit. And interestingly, from the organizational standpoint, it's come up that organizations that are not traditionally SRHR organizations are trying to provide SRH care because, immigrant women are going there for mental health care or something else, and then this is coming up as a gap. So I do think that there's going to be this interesting organizational, maybe not restructuring, and it's interesting to think about in the context of how these things are funded, but women are whole people, and like their mental health care is tied to their SRH care, is tied to their need for substance abuse care and things like that. So I think it really challenges the way the system is set up, because COVID has brought to light that there's a need for like, you know, going to one place where you can get access to all of those resources. But I'll let Jen and Malia talk about a little bit if this has come up in the interviews.
Right, if Jen?
Yeah, I'll just jump in and say, in a word, yes, mental health came up frequently during the interviews, both related to kind of clients, patients, program participants, and then also staff, organization staff. Kind of one quote that I kept coming back to in preparing this presentation, but that didn't actually make it into the slides, is from a maternal and child health provider in Minnesota. And she sort of asks herself, what is reproductive health care? That question is sort of expanded during this time to be more in the mental health area, which is a form of reproductive health care, but also just like the most basic needs people can't get access to. So I thought that was a powerful quote to speak to that piece. Malia, do you want to add anything?
Malia, anything? Pat?
Yeah, I mean, I think because most of the folks we were talking to were, you know, service providers, they're some when I asked them about policy, they were sort of like, oh, I can't really speak to that, because they're just really kind of on the daily grind of their everyday work. But the few that we talked to that are in policy advocacy work, I think they are, this is part of their long-term plan. But I think right now during COVID, there was just this feeling of, we can't even get anything that we've been working on for years. We can't get anybody to listen to us, because if it doesn't have to do with COVID specifically, then nobody wants to hear about it. And, you know, they said, while that's understandable, it's also really, really frustrating, because we're kind of like, you know, how do we prioritize certain, you know, campaigns if, you know, do we put all of our eggs in one basket just for it to be completely ignored once it gets to the right person? So not to, you know, make you feel discouraged, but that was kind of the feedback that I got from one interviewee.
That's great. That's really helpful. So can we go into, we have 15 minutes left. Let's
I think we have 1 minute.
Really?
Is it 12:45? I think.
Oh, we have 1 minute. Okay. So let you guys do just maybe the last, each of you take a few seconds to say some potential next steps. Let's start with you, Dr. Samari.
Sure. I just wanted to answer Dr. Garber's question. So we have a few definitive manuscripts in the works. We're attempting to, and as you know, Dr. Garber is better than anybody, you know, sort of write them as mixed methods papers, really bringing together the survey findings with the interview findings, but also I think the maps are brilliant and really do show sort of the policy response. So we're trying to include all of those things into individual papers, but if it becomes too cumbersome, we'll divide them out a little bit more. But so far, 3 papers, one focused on the SRH response, one focused on GBV, and then one that really talks about the need for these things to be integrated and how our findings thematically show that there's gaps in integration. So that's the current plan. And like I said, we would like to take some of these findings, and it's important to the Ford Foundation to take the findings back to the organizations that really provided information for this work, and sort of providing the materials that may be useful to them as well, whether it's like policy briefs or information that they can use in advocacy efforts. To circle back to Professor McGovern's question about what we can do, I don't think student and faculty advocacy should ever be underestimated, particularly under this new administration that's probably being inundated in this first 100 days with different policy ideas and notions and different things that people want. And all these issues are important, right? But if you're passionate about SRH or gender-based violence and prevention and services, then you have to be really targeted in your efforts and outreach in that space. And it could be things from writing op-eds or, you know, putting policy information out there, policy briefs. Policymakers ultimately are going to draw upon those materials, and And we're lucky to be a group of experts ultimately in this space and able to offer some of that feedback and information.
Thank you, Dr. Samari. Anything to close, Malia and Jen? I'm very confused about the timing because I have so many seminars. And Lizzie lost her signal and she kind of keeps us all organized. So anyway, final thoughts? No problem.
I don't think so. I just, like Dr. Samari said, I think I'm currently figuring out how to squeeze in this, as Dr. Garber's put it, 360 view into 2,500 words. So if anyone has any pointers on that, please send them my way. But yes, we are trying to get that out. And then Neha, who's on this call, for the other countries, we're kind of working on a 2-pager. So just a really short summary of this is what's going on in this country and some recommendations moving forward. So that will really force us to kind of hone in on the most important takeaways from this work. And, you know, that's something that's really accessible to a lot of people because it's short and sweet.
Thank you, Malia. Jen, anything to add? Last word?
Nothing much to add. I guess on the big picture level, I'm hopeful that as some of our interviewees express, this could be a moment for transformation and for change. And then kind of on the day-to-day, as Malia mentioned, I'm wondering how we fit it all into just a few pages.
Great. Of course, these are the challenges. So I really can't thank you all enough. I think I've decided to use the term, I'm always subjected to conversations around precision medicine. So I've started to use the term precision advocacy. We need to get much more strategic and precise about how we impact policy. And I think this research is really amazing. And I'm really proud to be a part of a team with you guys. So I will end us there, and I hope everybody can come next week because the global findings are super interesting. I have a conflict, so Dr. Casey will be moderating, but that's really rich as well. So thank you all for tuning in, and happy Monday.
Thank you all for joining.
Bye, everyone. Thank you.
Bye, everybody. Thanks so much.